Again, hello everyone. My name is Andrew MacHill. I'm an associate professor in the School of Nursing and in the Oregon Institute of Occupational Health Sciences. It is my great pleasure today to present or to introduce a collaborator of mine and a good friend who has become a good friend over the years, Dr. Quin Denfeld. Quin is an associate professor in the OHSU School of Nursing and in the School of Medicine, the Division of Cardiovascular Medicine, with a program of research that focuses on biobehavioral mechanisms of symptoms and frailty among adults with heart failure, with a particular focus on women and older adults. She's funded by an NIH R01 and an R21, and is also the next generation research co-director for the K-12 Building Interdisciplinary Research Careers in Women's Health Program at OHSU. She's also serves as an editor on numerous journals, and has won several awards, even recently winning one at the American Heart Association meeting, which we're all in the School of Nursing very proud of. But I met Quin, I think it was 2016, as a visiting postdoc, and they were having those postdoc meetups, and I went because there was free pizza. But Quin was the one presenting, and she got roped into it, and I was able to learn about her work and the work that she does at the School of Nursing. And I'm always been so fascinated by Quin's work, and she does such great rigorous science that I thought she'd be a great person to speak to our group here at the Institute. So with that, I hand it off to Dr. Denfeld.
Thank you, Andrew, and thank you to everyone for the invitation to present. Yes, I clearly remember that presentation in 2016, and I went for the free food and the chance to actually win a travel award. So I had some money to spend to go to conferences. So I think we're always looking for food and or money in this job. All right, I'm going to get started on my talk on frailty meets heart failure, lessons learned in the road ahead. So let's make sure it advances. All right. So here's an outline of what I'm going to talk about today. I'll give you a brief background on heart failure and frailty just to set the stage. Then I'm going to walk you through each of the different studies we've either completed or in the process of completing, which are labeled up here. And then I'll go through these in a little bit more detail. And then I'll wrap up by talking about the implementation of frailty assessment and frailty interventions, as well as in my humble opinion, thoughts on the next steps. I've put up here my, well, I still have the X account, but I don't use that as much. I have an email, and then I also recently have a website that we just got launched where a lot of this information will reside and will be updated as we move forward. All right. Oh, and I should say the first 3 studies are my lessons learned, and then the road ahead is the last 3 bullet points. All right, so heart failure. So a little bit of background on heart failure to set the stage. There are about 64 million adults living with heart failure worldwide, about over 6.5 million in the US, so a prevalence of about 2 to 2.5% in the US. Heart failure is the fastest growing cardiovascular condition in the US. There's about 1 million new cases diagnosed every year. This is particularly evident among older adults. And as we all know, the population is aging, and this is going to become an even bigger problem. Heart failure is the most common reason for hospitalization and rehospitalization among older adults, so among Medicare beneficiaries. What is heart failure? Well, it's a very complex and multi-system clinical syndrome. The definition's been updated to this one up here that was put forward in a consensus statement led by Dr. Beacom Boskert. And this is kind of the definition we're moving forward with, but it's a very heterogeneous, complex syndrome. How do we manage it? Well, that's actually evolved a lot since the days when I was a cardiac and surgical ICU nurse, and where we were doing certain things and using certain drugs that we now don't even use anymore. So it's been very interesting to see the landscape of drugs and devices change over the past couple decades. And I'm feeling very old just saying that. We have new drugs, we have new devices, but despite all of this, the outcomes are still poor. So the prognosis of heart failure, I think, is getting a little bit better, but still about 50% of patients will die within 5 years after diagnosis. And even more so for those patients within those 5 years or even beyond, they're living with pretty bad symptom burden, decreased quality of life, and decreased functional capacity, which is not only affecting them, the patients themselves, but their family members. and friends. Okay, so that's frailty. Now let's talk about, or sorry, that's heart failure. Now let's talk about frailty. So I want to spend a minute talking about what frailty is. The word derives from the Latin word fragilis, which means easily broken. The term has been thrown around for many decades. I mean, this is not a term that's new to most people, but it never really had a good clinical definition or measurement tool until about the early 2000s. So the geriatric medicine evolved, our geriatric colleagues have really led the way in the past 2 decades, advancing both the definition and operationalization of frailty. So most people now define frailty using this definition up here, which is largely centers on this overall decreased physiological reserves and increased vulnerability to stressors. So the body's slowing down and they aren't able to bounce back as quickly when they have a stressor like a hospitalization. The syndrome of frailty really derives from the system as a whole, and it's independent of any kind of particular system or chronological age. So we just kind of talk about it as kind of a global frailty syndrome or picture. So prior to the definition and operationalization of it, how do we actually assess it? So we did what's called the end of the bed assessment or the eyeball test, where people would stand at the end of the bed. This is, say, in the hospital, for example, they'd eyeball a patient and just say, oh, they look frail. Sometimes they would shake their hand, and if they had a weak handshake, they'd say they're frail. Well, that's really not a good way of assessing frailty. So again, and I should say frailty to me was what my grandfather pictured up here looked like, or what frailty was, is someone who was largely confined to a chair or a bed, unable to do the things that they wanted to do, any physical activity, always tired. In fact, he sat still for my figure drawing class because that's all he did was just sit. So he was a good subject for a figure drawing class, but unfortunately he had pretty bad quality of life by this point. But again, thanks to our geriatric colleagues, we now have a better understanding of what frailty is and having an operationalization and measurement of it. So the one that I use and many other people do is this frailty is this vicious cycle. And I'll walk you through what this means. So this is put forward by Fried and colleagues in 2001, the seminal paper that I think has like 30,000 citations, but to date. So you have an entry point into this cycle of frailty, which is usually aging plus disease. And you can see how the two probably compound each other. This means that you have a loss of muscle mass, which leads to weakness and tiredness. People start to slow down. They slow their gait speed. As a result, they decrease their physical activity. This decreases the amount of energy that's expended, and they have poor weight loss, or they have weight loss and poor nutrition. And then you can see how this just further compounds loss of muscle mass, and it becomes a very vicious cycle. All right, so one more kind of background slide, and then we'll dive into this intersection. So just to kind of lay the ground for this intersection of frailty with heart failure, it really behooves us to address the aging and heart failure issue first, which lays the foundation for how and when frailty intersects with heart failure. So in my opinion, we have 2 issues when it comes to heart failure and aging. We first have the aging of the population, as I mentioned. This has steadily increased over the past few decades. By 2030, about 1 in 6 people worldwide will be over 60 years of age. I think by 2050, it's going to be 20 to 25% of people in the US will be over 65 years of age. So that's going to translate, of course, to more hospitalizations with heart failure as a cause. And then it's also going to increase mortality rates with heart failure as an underlying cause. Let's see, there it is. Okay, so then we have the second problem is that the condition of heart failure in and of itself accelerates biological aging. So we now know that chronological aging and biological aging don't always match. Sometimes it is for better, sometimes it is for worse. And in the case of frailty, it's for the worse, where people will age more rapidly than what their chronological age is. So we have natural aging processes that we, of course, can't arrest, but this gets compounded by the condition of heart failure and likely other comorbidities that contributes to this accelerated aging or accelerated biological aging phenotype across many different systems. You have more inflammation. The term is called inflammaging or inflammaging. You can have sympathetic aging. a lot of different processes across the body start to age more rapidly. And again, this is important of any chronological age. So we have aging as in and of itself. We have heart failure, and as you can see, taken together, we're going to have what we will phenotypically observe as geriatric conditions, such as heart failure. So moving forward, so I began studying this intersection of frailty with heart failure in earnest around 2012 as I was a grad student at the School of Nursing at OHSU. So at the time, the literature was really just emerging, and there was probably a handful of papers that were out there. I think there was around 20 or so on this topic. And it's been very enlightening to just try to understand this intersection of heart failure and frailty, which again, were kind of two very large areas of research by themselves, but you know, to around 2012 had not been put so much together. And this has just taken off over the last decade. In fact, we see probably upwards of 500, 600 papers on this topic in and of themselves. So pretty exponential growth in this area. So what I want to do with my program of research is first understand where this intersection of frailty happens. It happens at some point from diagnosis to death. And in fact, frailty can even happen before diagnosis. But when it happens, why it happens, and then how can we importantly delay the point at which it happens, or maybe even I eliminate the point at which frailty becomes a problem. So in other words, this is just kind of capturing better health span for patients with heart failure. Okay, so I'm going to give two key things that we in this year 2025 have established in the field of frailty in heart failure. So the first thing is the prevalence of frailty. So it's been estimated, or it had been estimated to be high. However, when I was diving into the literature, as every good grad student is supposed to do, the estimates just varied quite widely. So I saw estimates of 15% to upwards of 90%. So really, we were just kind of shooting in the dark. We didn't know what the prevalence of frailty was. And so in order to ascertain where we stood in terms of the prevalence of frailty, we conducted a meta-analysis. And this one was published in 2017. And so based on the 26 studies that had measured some form of frailty up to that point, either in a multidimensional or a physical aspect, multidimensional being physical plus psychological, cognitive frailty, or just physical frailty in and of itself. We generated an estimate that about 45% of patients with heart failure, or about 1 out of every 2 heart failure patients, is likely frail. So that's pretty profound. And we've seen very similar prevalence estimates in our follow-up studies. And comparing that, and one thing to point out is to compare that with the estimated prevalence of frailty among the oldest old, so those who are 90 years of age and older. The prevalence is about 20 to 25%, or 1 out of every 4 old adults. So it's pretty profound that about half of heart failure patients are considered frail. And this is across the lifespan. This is not just an oldest old. So the second thing we've established in this field is that frailty is clearly associated with worse outcomes. There's been numerous studies, and now to the point where we have numerous meta-analyses, 2 of which are up here. On the left-hand side is a meta-analysis from Dr. Eric Quin's group that reported a 1.5-fold increase in the adverse outcome of death or incident hospitalization associated with frailty in chronic heart failure. Another meta-analysis from Isabella Uchmanowicz's group. This is the forest plots of the effect size of the relationship between frailty and mortality in heart failure. So this is just mortality. Across 29 studies, frailty conferred about a 48% increased risk of mortality in heart failure. That was significant for both outpatients and inpatients. So very similar results, somewhere in the ballpark of 40 to 50% increased risk of mortality or hospitalization. So seeing these outcomes and how frail patients are really having these poor outcomes has launched our field and focused our attention on understanding how, why, when, and for whom frailty affects people with heart failure. All right, so that was the background. So now I'm going to talk about my journey with heart failure and frailty beyond just that meta-analysis. And first, I'm going to talk a bit about my dissertation studies. I'm going to take us way back about 10 years ago, where I was thankful to be awarded an F31 through the NINR to do this study. And here's where I specified I wanted to measure physical frailty, where I'll talk about this on the next slide, where we look at 5 different criteria. But I wanted to dig a little bit more into the physiology of frailty and heart failure. So I wanted to enroll patients, or I did enroll patients, when they were scheduled for a right heart catheterization procedure to measure the pressures, flow, and oxygenation of the heart. So I met with these participants either before or after their procedure, and I assessed them on physical frailty measures. And of course, this being a dissertation study, we had 49 people to analyze. So I want to spend a second talking about how we measure frailty, which is a question I often get. So as I mentioned, there's the physical frailty kind of approach, which is one of like 2 camps, I would say, that's out there in the geriatric world. Physical frailty really just focuses on the physical aspects of frailty. The most commonly used measure is the frailty phenotype criteria. And when I was applying this to the heart failure population, I wanted to think through, like, does each of these criteria make sense for the population of heart failure patients? The 5 criteria are shrinking, and we measure that with unintentional weight loss of greater than 10 pounds over the past year. One caveat we had to consider is that patients with heart failure, their weight fluctuates a lot. And so we really had to dig into and ask them about, is this weight loss truly unintentional? Like, did you not want to lose this weight? And so that's how we've assessed it. It's been kind of our weakest link in our measure, I will say, though. We assessed weakness with both grip strength and 5 repeat chair stands. People more commonly use grip strength, but when I worked with Dr. Carrie Winter-Stone as part of my dissertation, she said, let's also assess lower extremity or lower leg function and see how people are doing, because that actually replicates a function that people are doing more often throughout the day rather than just gripping things. So we added chair stands to better replicate these functions, and I would have to say it's been very informative to see how well people or not well people get up out of a chair. We also do a slow gait speed measure to assess slowness, how their gait speed, their just traditional gait speed over 4 meters. We ask questions from the FACET questionnaire to ascertain physical exhaustion. And we're looking at like really extreme physical exhaustion. That's our cut point. And then we ask a question about how much physical activity they've done over the past week. If they do less than 1 hour per week, they're considered low physical activity. So you simply just add up these criteria. If they meet 3 or more, they're considered pre-frail. Sorry, I forgot to put up my pictures here. If they are 3 or more, they're physically frail. 1 to 2, they're pre-frail, and 0, they are non-frail. So the 2 results from our speed heart failure study. So first, we found that about 50% of the sample was considered frail, so similar to our meta-analysis. And then we just looked at, do physically frail patients have different hemodynamics compared to non-physically frail after adjusting for a composite clinical score? So those who were physically frail had significantly lower cardiac output and higher heart rates compared to the non-frail participants. So indicating that frailty and heart failure may be a manifestation of low output heart failure, more advanced hemodynamic stages. So this was, again, a small sample, but it just kind of gave us a signal that, again, body slowing down, there are some hemodynamic changes. The second paper was looking at the relationship between frailty and symptoms. Up until this point, we really hadn't seen how does frailty affect heart failure symptoms. And we found that those who were physically frail had significantly worse dyspnea. They had more shortness of breath. They have more excessive weight disturbances, like they were more likely to fall asleep while riding in a car after a meal. And they had moderate or greater depression, or more likely to have moderate or greater depression. And this remains significant after adjusting for the composite clinical score. And so really just seeing that physically frail patients had worse heart failure symptoms was one of the first looks at this relationship, and has since kind of launched a few areas spawning off of this work. All right, so then fast forward a few years, I was doing a postdoc fellowship in Beth Haubecker's lab. I was learning some basic science approaches, trying to beef up my skill set on biomarker assays, especially around sympathetic markers. And the Birch K-12 came up. This is the program that we have at OHSU, the K-12 program. And they had a call for applications, and I started thinking a little bit about how sex differences might play a role in the presentation of frailty and heart failure. So we know that there are sex differences in heart failure that might contribute to sex differences in frailty phenotypes. So kind of just some key points. Women are often older at diagnosis of heart failure. They have more non-ischemic causes of heart failure, like comorbidity-related causes like hypertension, obesity. This leads to them more likely to have a heart failure with preserved ejection phenotype. They may have different symptom presentations, or maybe even more so different biological mechanisms of symptoms. Women make up actually about 50% of the heart failure population. However, they have been grossly understudied across many different research studies, especially clinical trials of drugs and devices, where they make up about 25 to 30%. So much of this is outlined in this review article by Dr. Anuvala. But really kind of the bottom line is that women are not just small men, or Barbies are not Kens. And this is the title of a talk I was given, so I keep including this, but we just have to remember that Barbies are not small Kens, and that women are different than men when it comes to heart failure. So back to kind of the Birch and asking a research question. Okay, so we know that we have sex differences in heart failure. Does this contribute to gender differences or sex differences in physical frailty phenotypes? So I came across, when I was digging into the literature again, this concept, or this phenomenon of the male-female health survival paradox, where women live longer lives than men. We know this, but they actually have worse quality of life and health status. So women are living longer, but just with worse health status. This has been known in the geriatric world, but is it also true in heart failure? So I proposed the question, in heart failure, are women more likely to be frail than men? Based on the two premises of the male-female health survival paradox. And second, much of what we know about the intersection of heart failure and frailty is based on studies that really predominantly enrolled men. So we really hadn't taken a deep dive into this. So I proposed the study, and I was very fortunate to get it funded in 2017 through the Birch. All right, so while we were in the process of running this study, of course, as an early stage investigator, I couldn't just sit still. I needed to keep publishing. So at this time, I fortuitously I started working with Mary Roberts Davis, who's now an assistant professor at the School of Nursing. And I said, hey, I really want to take a deep dive into understanding this phenomenon of potential sex differences. And I had been talking to my mentor, Dr. Chris Lee, and he's like, well, why don't we just look at your meta-analysis, re-examine it again, and pull some papers and see if there actually are sex differences in the prevalence of frailty. So we did a review of the literature, brought everything up to date to 2021. And we had 29 studies for this meta-analysis, and we showed that, yes, in fact, women are more likely to be frail than men in heart failure. In fact, women have about a 10% absolute higher risk of being frail compared to men. So this, again, was just another kind of eye-opening signal to see, oh, wow, women are, in fact, more frail than men across many different studies. So back to the study that I was funded to do, the GAP Frail Heart Failure Study. I enrolled patients from outpatient cardiology and heart failure clinics, and brought them in for study visits, which I'll describe on the next slide. And we had 115 people with completed study visits, of which 49% were women. In fact, I had to close the study to men for about 3 to 4 months at the end because we needed a lot more women. So that's a whole other topic, but trying to bring women into research studies is can be a big barrier. So bringing them into the baseline study visit, we had, well, it's been renovated since, but we had a health and human performance laboratory at the School of Nursing, where we did a few things. First, they had a DEXA scan so we could ascertain bone-free lean mass and visceral and subcutaneous fat mass. We collected blood, we did a fasting blood draw, stored all those samples in Oaktree, and then we did some physical frailty assessments, the same thing as what I described previously. They also had completed a survey regarding symptoms and a few other sociodemographics. After that, we followed up with them for a year, asking them every 3 months if they had fallen, and if they had fallen, if they had an injury as a result. And then every 6 months, we ascertained clinical events. So I'm going to give you 3 primary papers I'll present to you that are our findings from this work, and then one more recent one that we've just submitted for publication. So this first paper, which was kind of our primary paper, was just telling the world that, yes, there are sex differences when it comes to frailty and heart failure. Yes, we'd shown this with our meta-analysis, but in this prospective study where we were very focused on recruiting about 50% women and focusing on frailty, physical frailty, that is, comparing women versus men, we found that, yes, full stop, women are more likely to be frail than men. Second, when we examined the individual physical frailty criteria, we found that significantly more women than men met 4 out of 5 of the physical frailty criteria, including weakness, slowness, physical exhaustion, and low physical activity, indicating that it's still just kind of the phenotype or the combination of these different criteria that are leading to frailty in women. And then, of course, we had to adjust for some other sex differences. As I've already talked about, there's other significant sex differences in heart failure. So even after adjusting for these many different covariates, we still saw that women had a higher odds of being frail. In fact, a 4.6 higher odds of being frail compared to men. And then in the paper itself, which I won't talk about today because it takes a little bit too much time, but we have potential differentiating characteristics of frailty in women and men separately, looking at it, doing a sex stratified analysis to start seeing some signals of things that are driving frailty in women and driving frailty in men. So the second paper was looking at the biological mechanism. So as I mentioned, we collected blood and we assayed a number of different biomarkers. And so this one I was really excited about because since the early days of my grad school, I really wanted to dig in deep into the biological mechanisms of frailty, what's going on from a biological and physiological level. So we picked 9 different biomarkers to capture these different processes. So things like myocardial stretch and congestion with NT-proBNP, sympathetic activation with norepinephrine and its metabolites, insulin resistance with insulin and glucose, systemic inflammation with TNF-alpha, adipose tissue with adiponectin, skeletal muscle dysfunction with myostatin, and catabolism with IGF-1. So we measured those in the 113 samples we had because 2 participants hadn't given us some blood. But we found that after adjusting for a couple of different covariates, we found that those who are physically frail had significantly lower insulin-like growth factor 1 or IGF-1, lower adiponectin, and lower myostatin, indicating a very catabolic, dysfunctional adipose tissue, muscle, skeletal muscle phenotype or kind of physiology going on with patients who have frailty. And then we also actually saw some interesting sex differences too, in that IGF-1 and myostatin were associated with frailty in men, but not so much in women. In fact, it kind of disappeared. So I think we're still a little bit in the dark in terms of what's going on physiologically with frailty in women. And then the third paper was another of our primary analyses or primary aims. So as I mentioned, we tracked patient outcomes over a year post in-lab assessment. So we collected information on clinical outcomes like ER visit, hospitalization, VAD transplant, and all-cause death. We also had collected data on health-related quality of life at the same time as their frailty assessment. With the help of an internal medicine resident, Dr. Sarah Archer, we adjudicated all the events and then took a look at the findings together. And what we found was really interesting and in line with what I was seeing with the broader frailty literature. So first on the top, frailty was associated with worse quality of life overall. So worse total and physical quality of life. But then looking at this in a sex stratified analysis, women had significantly worse quality of life if they were frail, but this effect was quite a bit diminished when it came to men. And then interestingly, on the clinical event side of things, it was somewhat the opposite. So interestingly, frailty was not associated with an increased hazard of events in this population. But when we looked at this sex stratified, you can see that the hazard ratios are a lot stronger compared with women. And in fact, when we looked at the physical frailty score on a continuous score, higher levels of frailty were associated with worse clinical outcomes in men. So basically, the bottom line from this is that in women, physical frailty may translate to worse quality of life, but not necessarily worse clinical outcomes. And for men, it's the opposite, worse clinical outcomes, but not necessarily worse quality of life. So a lot to unpack with that one there. And then recently we looked at, I wanted to broaden out a little bit more and see, are there some social risk factors that might be associated with frailty and heart failure? So leveraging data from both the gap-frail heart failure study and the SPEED heart failure study, in which we had measured sociodemographics in the same way, we took a look to see, is frailty associated with any of these social risk factors? And of course, we were limited in the social risk factor data, but we did have data on, of course, sex, again, minority racial group, education, financial, a financial question, basically, do you have enough to make ends meet or not? A question on employment or retirement, and then a question on marital status. Are they single, widowed, divorced, married, or partnered? And do they have someone to confide in, which is a proxy for social isolation? So the three things that we found from this analysis were, one, let me put this up here. One, the block of social risk factors significantly predicted frailty above and beyond the three clinical predictors, that is age, functional class, and comorbidities. Two, retirement or unemployment was significantly associated with a higher odds of being frail. So perhaps indicating that retirement or unemployment is a sentinel event for patients with heart failure. And three, after accounting for all of this, female sex is still significantly associated with the higher odds of frailty. So despite whatever we control for, it just seems that women are more frail than men. And the retirement unemployment piece is really interesting and something that I think is worthy of diving into. And I have to say, my Ph.D. student Zijia Wang helped to dig into literature on this, but thinking about, is this increased financial strain and healthcare costs that's making it harder to manage heart failure, resulting in frailty? Is it kind of a lack of overall daily structure and reduced physical activity that's leading to frailty? Or is it lack of workplace connections leading to loneliness, isolation, and physical frailty? Or is it all of the above? Or maybe there's something else going on. All right, so I'm going to talk now, going back to the biology a little bit more. This is 2 slides on our recently published ProFrail heart failure study, which is a small study I got funded by the MRF as a new investigator. So as I had shown you earlier, we previously dug into the pathophysiology of frailty and heart failure by examining specific targeted markers like IGF-1 and myostatin, but I knew that was just kind of scratching the surface in terms of the physiological milieu. So as a next step, I wanted to investigate a much broader array of proteins through proteomics, since many of you know that proteomics can provide an unbiased evaluation of samples or proteins in the blood, and to help us identify candidate biomarkers and pathways. So the goal of this study was to perform a pilot discovery-based proteomic analysis of plasma samples collected from our gap-frail heart failure patients. There's a lot of methodology that goes in behind this, but really briefly, I propensity score matched patients in the gap-frail heart failure study, frail versus non-frail. We ended up with 21 matched pairs, in which these patients were matched on key characteristics like age, comorbidities, heart failure characteristics, and the only difference being one was frail and one wasn't frail. Sent these samples off to PNNL, where they did a proteomics analysis. From these samples of frail versus non-frail, they identified over 2,600 proteins, and then using a traditional volcano plot of log2 fold changes compared with the p-values, we found 27 proteins that were significantly different 10 that were downregulated and 17 that were upregulated, as you can see in the tables here. And then as one more level of constraint, I just looked to see, are these proteins significantly down or upregulated across the 3 plexes? And the ones in bold are the ones that were significantly identified across all 3 plexes. So namely matrix metalloprotease 14 was downregulated in physical frailty. And then in the upregulated side, we saw a couple of immune markers like immunoglobulins and a couple of markers of cellular detoxification and stress response that were upregulated with frailty. So very small sample, but gives us a few signals. And this is a figure by Dr. Linda Freed, and so I can't take credit for it, but it kind of just captures the processes that I think are starting to go on with frailty phenotype, which you can see at the top. So from a cellular molecular level all the way up, what's going on, perhaps some stress response, challenges with the immune system, cellular senescence. So a lot, again, to unpack with this, but giving us a few signals here and there. All right, so the road ahead in about 10 minutes. So I'm going to talk a little bit about our 2 main studies that we're wrapping up, the R01 and R21 that Andrew mentioned. So first, the R01. So this study is actually focused on symptoms in heart failure. So we're enrolling patients who are hospitalized for heart failure, we've closed enrollment, and we're tracking symptoms after hospitalization to see how symptomatic they are. And so that'll be the primary focus of this. But as one of the independent variables, we're seeing how frailty also tracks with symptoms. So we're collecting a lot of data around frailty, and we'll be able to dig in deeper in terms of how frailty intersects with some of these other things like biomarkers and symptoms. And then we'll also be able to see how frailty tracks over time. And so these are some very preliminary unpublished data looking at the Sankey diagram of how frailty changes over time. And I think my first takeaway when I saw this is, well, first of all, we know a lot of patients are frail, but frailty is a lot more dynamic and changes states a lot more often than I thought it would. In fact, only 17 patients out of the 75 in this interim analysis remain frail across the 4 time points. So people are changing categories a lot, which I think is also good news to share with our patients to say, if you're frail, it doesn't mean it's a foregone conclusion you're going to stay frail. There's actually a lot of changes that can happen over time. So that's all I have to say about biomes. We're still in the process of cleaning the data and getting that ready to analyze, so more to come. PRISM is our other study. This is the R21 study that was funded by NINR as well. And in this study, I wanted to see, okay, if you're physically frail, does that impact the ability to take care of yourself or to perform self-care? So in heart failure, self-care is a big deal. You have to maintain your health, monitor for symptoms, manage those symptoms. Well, there's a lot going on when you're doing this at home or wherever you might be. And if you're frail, I was curious, if you're frail, does that impact the ability to do these self-care behaviors, especially monitoring and managing of symptoms? So this is our protocol paper that we published a year ago. And so I'm going to present 2 things from this. So first, hot off the press, this is our AIM-1 analysis, and actually you guys are the first to hear about this, so thanks for the opportunity to talk a little bit about it. But as I mentioned, I actually hypothesized if you're physically frail, you will have worse symptom monitoring and management. There's not a lot of literature out there, so this was largely kind of based on triangulating some different pieces of information. But in fact, the opposite was true. So physically frail patients with heart failure had better symptom monitoring and management behaviors, about 8 to 10 points higher. I don't show that up here, but that's based off this measure that is clinically relevant. The top figure is showing that after adjusting for a risk score, a composite of different clinical variables, for every 1 point increase or better monitoring and management, you actually have a higher odds of being frail. So different. And as one of my collaborators, Chris Lee, says, well, that's totally dawned on me that they would do that because they are driven to have to take care of their symptoms because they are physically frail. So then the other question was, physical frailty, is it associated with worse clinical event risk, especially if you have worse symptom monitoring or management. And so it's kind of a slightly different finding that we're seeing here. So frailty is associated with worse clinical risk, so all-cause clinical events over 6 months. But it did not matter whether you had adequate or inadequate symptom monitoring or management. It was all just about the frailty in predicting the 6-month clinical events. So that's our first finding we have so far. And then I also want to mention one other thing that we're doing. So this is actually a mixed method study where we have a quant aim, which is what I just presented, and then a qual aim where we interviewed patients to dig in deeper into the relationship between frailty and self-care behaviors to see, are there things in there that we can pull out to help identify needs and points of intervention. That is still in progress, but one thing I want to pull out is we've also at the end asked participants in the interviews, have you heard of the term frailty? What does the term frailty mean to you? What's the relevance of frailty to you? Because one thing I've been percolating is the patient's perspective of frailty. What do the people actually think of frailty? Going back to one of my first slides, we all kind of had this idea of what frailty is, but if we're actually going to address it, we have to understand how people are actually thinking about it. This is just a little mini review we published earlier this year, looking at the literature out there. But let me give you a few exemplar quotes, comparing, these are four quotes, two physically frail, two pre-frail. So you can, I won't read everything, but you can see that how people actually perceive physical frailty. So they say, oh, especially little women that are real frail, real thin. So they're thinking of these like thin women who have thin skin, very small, Frailty is also something related to or akin to China, China that's old and thin and crumbly. And then pre-physically frail people, they also reference women, interestingly. Everybody I've noticed, or I shouldn't say everybody, but most people are very quick to pinpoint somebody else who's frail, but they won't necessarily ascribe frailty to themselves. This last one is interesting because they talk about frailty being a very charged word, and they relate it to this thing with pregnancy where, women in their late 30s or beyond, if they're pregnant, they're considered a geriatric pregnancy, of which I was for my last child. And it does carry this kind of charged concept. So if we're using this term frailty, does it have the danger of being misinterpreted? So a lot to come from that. And then I'm going to kind of just breeze through these somewhat quickly because this is a little bit more for the clinical implementation of things. But I do think it has a bearing for future research. So assessment of frailty, going back to just, well, we have a definition, how do we actually assess it? We know that the eyeball assessment, end of the bed assessment, and handshake test are out. We know that those aren't valid, and actually studies have shown that. But there's actually over 60 or 70 assessments available. So the frailty phenotype criteria, the one that I've talked about and that we use in our research, is one of the most commonly used ones. The other one is actually called the Frailty Index, which is a multidimensional deficit-driven frailty index, indicating that basically you sum up, you have a candidate list of 30 or more variables that are linked to aging. And if you just basically sum up yes or no, do you meet those? And if you are above a certain threshold, usually around 0.3, you're considered frail. This is a tool that's used often in registries or larger data sets because it's easy to use. You don't have to go and actually have people do chair stands or grip strength or gait speed tests. So this is a consensus statement that is specific, or we wrote it for the International Society for Heart and Lung Transplantation to help advance this area, specifically in advanced heart failure, because this is absolutely a patient population in which frailty does need to be assessed as people make decisions about advanced therapies. But there's a lot of things we can take from this moving forward. A few of the key points from this, are that one, how do we disambiguate frailty or physical frailty from all of these different related concepts? So this is just one figure in which I basically kind of put up what I think, here's the relationship. They're overlapped, but they're distinct concepts. But we do know that all of them together do increase vulnerability, especially in advanced heart failure. Here's our suggested approach for frailty assessments, which I won't go through in detail, but you can reference the paper for that. And then quickly about management, what are we going to do if they're frail? So this is the next question I get. My patient's frail, what do I do? And so this is where I've been using is that we have to think about how do we manage frailty in the patient who has heart failure? So how do we kind of address the frailty picture with exercise, nutrition, drawing from the broader frailty literature? And then the other side, but also related, is how do we manage heart failure in the patient who is frail? Do we treat them with guideline-directed medical therapy? How do we make decisions about advanced therapies? And in my opinion, it's probably not an either or, but a both, and more evidence is needed. And this is just kind of captures like what I think about in terms of next steps with frailty. This is a paper from 2012, so a little bit older, but I still reference it quite often. It's very specific, or it's specific to LVAD, which is left ventricular assist devices in heart failure, but it can be extrapolated to other heart failure patients or patients with other comorbidities. So you have frailty in and of itself, but is the frailty caused by cardiovascular causes, or is it caused by non-cardiovascular causes? And I think identifying those mechanisms is going to be key to then saying, okay, if it's a cardiovascular cause, we need to treat with medications, advanced therapies. If it's non-cardiovascular, we need to do something more around exercise, nutrition. They're not mutually exclusive, of course, but kind of pinpointing these different mechanisms and will help us ascertain, okay, what kind of therapies do we need to institute? And then this is just lastly a figure that was published in New England Journal of Medicine in this really nice review article on frailty in older adults. If you're interested at all in just kind of understanding frailty a little bit better without kind of that heart failure layer, this is a good reference to start with. Ken Rockwood is actually the architect of the Frailty Index, and he's a kind of one of the foremost thinkers on this. But this just kind of gives us an overview of kind of from fit to end stage frailty. What do we do with frailty? And I think I love the end quote of this, which is that frailty assessment should not be used as a convenient way to withhold potentially effective treatments, but rather as a tool to facilitate patient-centered care. So let's wrap up with take-home points. Frailty, as I mentioned at the beginning, is very highly prevalent. About 50% of patients with heart failure are frail. It is prognostically significant. We showed that frailty is associated with worse hemodynamic markers, a few biomarkers and proteomic markers that are upregulated or downregulated with frailty. Women are more likely to be frail than men, even after adjusting for a multitude of different confounders. I keep seeing again, time and again, women are more frail. Physically frail women seem to be at this point painting, there's more of a picture of more comorbidities, especially type 2 diabetes, worse physical symptoms, worse quality of life, and in fact, lower education. That's not something I presented earlier, but that's one thing we also saw in that social risk factors paper, that lower education seemed to be a bigger predictor of frailty in women than men. Physically frail men, we see more comorbidities as well, worse depression and dyspnea, changes in biomarkers, worse clinical outcomes. And then we also know that frailty needs to be assessed in heart failure using a validated tool. So moving forward, we have to be clear about how we're approaching frailty, use some kind of validated tool. I think we're beyond the point of just arguing which tool is the best. We just need to assess it. Managing frailty is going to be very multifactorial, but I think really focusing on the mechanisms of frailty will be helpful in identifying the management strategies. What's on the horizon? I think I put this up here because I feel like there's a lot of different directions we should go. And I think the more that we unearth in terms of our research, the more avenues I think we need to pursue. So for me, like one of the big questions is, why are women more frail than men, but yet they still kind of have better clinical outcomes? Not necessarily worse, not necessarily better symptoms or quality of life, but but better clinical outcomes. So what are the mechanisms underpinning this, from the cellular to the environmental? What's going on with this frailty as an effect modifier thing? We're seeing more of in drug trials. So a lot of drug trials in heart failure have been looking to see if you're frail at baseline, albeit using the frailty index, do you benefit from these drugs like SGLT2 inhibitors? in fact, frail patients benefit more. So they start at kind of a lower level, but they're benefiting more than the non-frail patients. And then lastly, should we reframe frailty to avoid it being this kind of negative label? So better understanding the perception of frailty in order to have better uptake of assessment and management of frailty. So basically, as I'm thinking of this, is like, how do you have the frailty talk with your patients who have cardiovascular disease? Because this is something we absolutely have to address. All right, I'm gonna end here with this, and then so I want to thank my lab members, my collaborators, mentors, co-Is. I mean, this is not exhaustive. I just didn't have enough room to put everybody up there. I also appreciate my funding, and then lastly, I want to say happy birthday to my grandma, who actually turned, let's see, she's turning 100 today. And so this is my grandma with one of my kids, and she's turning 100. So even though she has heart failure and she's frail, I think there's still a lot to, I think you can still live life. There's still a lot to be learned and to live. And so I just want to end with that. And I'm going to stop sharing.
Thank you so much, Quinn. If anyone has any questions or comments, please feel free to lift your hand or put them in the chat. I'll open it up. I'm curious to that figure that you had of the preliminary or pre-published data where, you know, frailty seems like a pretty dynamic thing, at least in your sample, going from frail to pre-frail to, you know. And I'm curious if you saw any trends of what people were doing, or what are some of the, is it just the exercise and diet that's moving people in this direction, or what are some of the common things that you're seeing?
That's a great question. I don't know. Those are all things I want to dive in deeper into. So that's something that we will look at in parallel with these data. So we have, I mean, we'll be able to track like their level of physical activity. I mean, well, that's part of the physical frailty criteria, but we do have more nuanced data on their physical activity, like what kinds they're doing. So we'll have that. We'll have information on kind of appetite. We will have information on a lot of medications. So that's probably one that we will absolutely pursue, is to see are certain medications, or if you're in kind of this trajectory of improving, we'll have to make some decisions about, you know, are you static, frail, static, pre-frail, or like improving, not worsening, something like that. Again, we don't quite know yet, but if you're in one of those trajectories, are there certain things that differentiate you? So again, kind of the traditional female versus male, age, maybe some sociodemographics, but then yes, the medications, the heart failure aspect of that, and then what they're doing, how well they're exercising. We'll have sleep data, or we'll have like how the sleep related impairment at least. So we'll be able to see like, are there certain things that some groups are doing better than the others?
Professor Shea.
Hi, thanks for a great talk. Very, very interesting. I'm wondering, I've heard that there's not necessarily a cult, but a theory that if you do bodybuilding early in life, it will help preserve longevity because of the avoiding the muscle loss is a big deal in that. So what's the actual scientific theory on that? Should 20-year-olds do bodybuilding and suck down creatinine drinks like there's no tomorrow?
Oh my gosh, that's a great question. I'm probably not qualified to answer that, but I would say my opinion is that preserving muscle mass, we know, is important. How you do that should probably be by means that are scientifically proven. So taking substances that increase muscle mass at the expense of other things could probably have a detrimental effect down the road. I don't know the literature well enough on specific things like creatine, but I would say that the science needs to evolve to better understand the long-term effects of that, but maintaining muscle mass through at least the established pathways of exercise is probably the best approach to take at this point. If anyone else has other thoughts on that too, I'd love to hear them.
Thank you.
No other thoughts, but it brings up an interesting question. So like the path to frailty, where does that start? Is it starting in an early age, or is it something that you hit a cliff and fall? Or like when we're thinking about this in a trajectory kind of standpoint, what does that look like?
Yeah, another good question. And I don't think we know that well enough. I mean, we do, the pathway to frailty is so, there's multiple pathways to frailty. So multiple roads leading to that. So as I talked about earlier, we have the entry point of aging and disease. So at some point, all of us are going to become frail because we just age, and that's kind of what happens, right? So it is a downward decline. I hate to say that, it sounds very ominous, but the way I picture it is that we want to keep that trajectory as flat as possible so that you kind of reach older age at kind of the most optimum health and less frailty that you possibly can. The way I've seen it is that with certain stressors or as you add more diseases, it just kind of makes that line go more steep or steeper. So yeah, I mean, like I don't know in terms of the broader kind of geriatric literature, they do have like longitudinal studies on frailty. And most of them are pretty ominous in that if you're frail, you kind of stay frail. If you're pre-frail, there is some kind of movement that happens. In heart failure specifically, I think it's a lot more dynamic because we have a lot more, there's potentially more stuff going on than rather this just like steady downhill in like kind of your traditional aging perspective. And in fact, Mary in her Birch study showed that women, so she was looking at patients who were just recently diagnosed with heart failure and looking at sex differences therein. But what she noticed, because I asked her to throw in a frailty measure, is that a lot of patients were actually coming to a diagnosis of heart failure already frail, and women being more frail than men, in fact. So there's something even going on. Is it because of the heart failure developing? Maybe. Is it because of something else? Maybe. But yeah, there's a lot to unpack in terms of the trajectory. We need a very large cohort study, lots of money to do all of this.
Okay, seeing no other questions. I know we're kind of towards the end. I had one last thought. So Steve made me think of this too. So when we study patients with obstructive sleep apnea, men and women, they present somewhat differently with sleep apnea. So it's very difficult in our studies to find women that actually meet the criteria for sleep apnea a lot of times, unless they have very severe apnea. And so it has had us consider at certain points whether we should be thinking of them similarly or categorizing them similarly. And I'm curious with frailty too, because you're seeing this disconnect between the frailty and the clinical outcomes. If men and women should be categorized in a different way for frailty, if you're catching them at different kind of levels where it doesn't match with the clinical outcomes. Am I making sense?
Yeah, is it maybe more around like the criteria for assessing the frailty? Yeah, like with the sleep apnea, because, and this is also common in heart failure too, is that should we have sex-specific criteria for ascertaining frailty? And that's a great question. So that was something that actually I have been thinking about. Is this something that is because we're skewing the frailty criteria to be a little bit more, make it more likely the threshold's lower for women to be frail. I think that still is a looming question, but I think and we've seen this across multiple other contexts in which frailty is measured in different ways. Like even if you look at looking at muscle mass or muscle strength, I mean, granted, there are sex differences there, but if you have sex-specific criteria, women still are more frail. So I think it is a worthy pursuit to make sure that we are actually capturing frailty well in women versus men. But yeah, that's a bigger conversation we have to have within the scientific community. But it does unearth a lot of questions about how we are actually measuring things, and are they capturing, is there measurement and variance across all of these different measures.
All right. With that, I'd like to thank you, Dr. Denfeld, for a great presentation today. And I'm sure if anyone has any other questions, she'd be happy to answer any questions. Or if you just see her around campus, say hi. But
Yeah.
thank you so much. And thank you everyone for attending.
Yeah,
Thank you so much.
Thanks for doing the work you're doing, and a great presentation.
Happy birthday to you.
Dr. Shea.
Oh,
Happy
yes.
birthday to your grandma.
Oh yes, what is the secret for your grandmother? Does she drink a lot of Scotch whiskey?
Yes. Actually, she has a fuzzy navel every evening.
What? A fuzzy?
It's called a fuzzy navel. It's vodka and peach schnapps and orange juice. And it's like a college drink, basically. You know, I don't know. I feel like she's like an N of 1 study I need to conduct, because I don't know if it's like the Scottish blood, if it's the, you know, moving to America with 2 young children and trying to figure things out. But I don't know. She ran her first marathon at age 77 or something like that. So she's pretty stubborn, I will say. I think it's her stubbornness. Actually, I'll end with that. It's her stubbornness.
Scottish stubbornness. Brilliant.
So you can make it a double tonight.
Yep.
Okay.
All right. Thank you. Have a good
Thank
afternoon.
you. Bye.